Hello, and thank you for joining us for the Minnesota Veterinary Medical Association's National Vet Tech Week webinar. This session for CVTs in the state of Minnesota is one of our ways we are thanking you for all that you do for the veterinary profession each and every day. I'm Maria Nellison, Certification Coordinator for the MVMA, and I'm pleased to be your moderator for Equine Emergencies, Be Prepared with Shayna Leminis. If you have any questions during the session, please type them in the Q&A area during the session. I would like to take a moment to introduce Shayna. Shayna has worked as a technician since 2011 in both small animal and academia. She went on to obtain a specialty in equine veterinary nursing in 2015. She is a senior veterinary technician at the University of Minnesota Large Animal Veterinary Medical Center and works mainly with surgery and lameness. Her greatest interests outside of large animal surgery are emergency medicine and hippotherapy. Shayna has also co-edited a textbook for Elsevier, Mosby's Comprehensive Review for Veterinary Technicians, 5th edition. She lives an hour south of the Twin Cities with her 8-year-old daughter and boyfriend. They have 2 dogs, a Vizsla Cross named Daisy and a Field Springer named Maisie. Thank you again for lecturing, and it's all yours, Shayna.
Thank you for having me. I am so glad to be here with you guys, even though it's a virtual conference. It's good to be here. I will jump right into it. Equine Emergency is one of my favorite things to do with my free, not free weekends. So this is one of my favorite talks to give. I will start by mentioning that I do have a specialty in equine veterinary nursing. So if you guys have questions about the specialty process, what's involved, why one might like to do that, I would be happy to answer those questions as well. There is a talk going on Facebook Live tonight as well about becoming a vet tech specialist. So, equine emergency medicine, whether you're in the field or you work in small animal, I think we can all relate to the thought that maybe you're newer or maybe you just don't know what to expect. And this picture kind of says it all for me. This is how I felt each and every time. Back then we had Nextel, but my Nextel went off saying that I had an emergency coming. That awful moment when you realize this is your circus and those are your monkeys. We are afraid of the unknown. So if I can bring to light a little bit of what we do in the referral hospital and how we approach emergencies, maybe it can make you feel better the next time you are faced with one. Okay, so the first one I'm going to talk about is colic. Whether we work with horses every day or not, you've probably heard the word colic. It does not only apply to horses, it applies to human babies, it applies to just about every species on the planet. But the definition of the word colic is abdominal pain. And in veterinary practice, we use that as both a symptom and a diagnosis. So we'll say, we have a colic coming in 20 minutes, or we'll say, gosh, you know, Eddie in the back barn, he's acting colicky today. Either way, it's just a sign that they have some abdominal pain going on, but it could be caused by so many different things. So, clinical signs of colic, if you work with horses, you know this stuff, and it's just a refresher. If you don't, I'm going to go through all of it for you. So, anytime an animal is painful, whether it's a horse or not, they're probably going to have some sort of elevated TPR. Their heart rate's going to be up, maybe they're kind of panting or puffing, and their temperature might even elevate due to pain. Horses tend to lay down and roll to show that they are uncomfortable. Maybe they just stand up and then lay down 52 times in an hour. Sometimes they literally point to where their pain is with their nose by flank watching. Usually they won't eat because I know when I have a sore stomach, I'm not going to be very hungry. And their gut sounds are going to be either very quiet or absent. In addition to this, depending on the type of colic, Maybe they're acting pretty quiet and not quite themselves. Maybe they're really bloated. They look like a blown up balloon. Or their stomach is just kind of tucked up, and their mucous membranes can be a variety of colors and textures. They can be tacky, they can be purple, they can be white, they could have that infamous toxic line. All or nothing, any combination of the above. What do these things look like? Well, we know in horses what an elevated TPR is. A heart rate above 44 is considered elevated, that's abnormal. And a rest rate above 24 is considered abnormal as well. Their temperature should be between 99.5 and 101.5. So if it's above 101.5, it does indicate some sort of problem. And then if they're really tucked up, if their abdomen is really tucked up, that's usually a sign that there's something going on as well. So what do these things look like? I put a lot of pictures in this PowerPoint, so hopefully that will be entertaining even if you know some of this information already. The guy in the bottom left there, that's one of our teaching horses. That's our stallion, Mac. When he first came to us, he decided that the girls were so pretty in the herd that he just couldn't eat or drink his water. And so what did he do? He colicked. So this is one of the first shots of him out in his paddock, starting to get down and do his serious rolling business before we brought him into the hospital and treated him. So the horse is going to go down, it's going to roll. Maybe it just does it once. Maybe the horse does it really frequently. Maybe they're doing this in combination with other clinical signs. Maybe this is the only thing that they do. Maybe they don't do this at all. They're all individuals and they all handle it differently. The downside to a horse going down and rolling is that if they're in the stall and maybe they're already hooked up to fluids, or the very rare case when they're on fluids at home, maybe they're owned by a veterinary professional. They go down and roll, they usually throw their feet in the air and they catch that fluid line, and then they're getting a very expensive shower. So, pawing or kicking. Our horse up in the top right here is pawing, just clearing one spot in the shavings, showing, hey, I'm a little uncomfortable. Some horses will do this when they're angry or upset as well, or nervous, but it is a common clinical colic sign. Our bottom left there, that's Mac again. He was kicking at his belly, saying, hey guys, this is where it hurts. Shows that they're agitated, shows that they're uncomfortable, indicates that we should be looking further into what's going on with them. Flank watching. This pony is just kind of pointing straight back to her abdomen, saying this is where it hurts. They do this sometimes while they're laying down too. They might be laying in sternal and just kind of reach back and flank watch a little bit. Some of the more stoic horses, this is the only thing that they do. And so it's not very dramatic. If you're not paying close attention, maybe you don't catch it because they're just laying down, but it is a very common clinical sign. It's a very sad looking little pony, not playing with their ball. We have had many horses come into the clinic and the owner says, you know, this horse is colicking, it's just not right. And if I were to, you know, I don't know the horse, I look at the horse and I say, horse looks fine to me. Heart rate isn't even really elevated, but the owner is insistent that this is not how this horse behaves, that this horse is normally trying to run people over. And you investigate further and you find that indeed they are colicking, but they are a very, very stoic animal and they don't want to show it. And then we talked about inappetence. If your stomach hurts, you're not going to want to eat. And we always pull food away from them anyway once we have confirmed that they are colicking. You don't want to add more food on top of the problem. So if I hear that a colic is coming to my clinic, and again, I'm in a little bit of a different situation. I work at the university. We do not do farm calls. All of our cases come to us on a trailer. So I am one of those people that works inside in the warmth when it's cold outside. And some people would say that we don't really live in the real world. So we don't do ambulatory practice. But a lot of this stuff does apply to if you're going to the farm as well. So the things that I want to be ready for if I hear colic is coming in 20 minutes or an hour, or if I hear, hey, let's go out to this farm and check out this horse that's colicking. I want to have my stethoscope and my thermometer. I want to be able to do a quick assessment, do a TPR, and listen for gut sounds right away on arrival. The other thing that we pretty much always do at the university, because we have a lab at our disposal right away, is we run blood work. In the room with the horse, we would run a PCV-TP, and then if there's any chance the horse is going to surgery or that the horse truly is colicking and needs to stay with us, we're going to run a CBC chem to find out what's going on inside that animal. Veterinarian is always going to do a rectal exam to try and feel if there's anything out of place or if there's some gas buildup. And then we pass a nasogastric tube as well. Horses are unable to vomit. A lot of you probably already know that. So passing a nasogastric tube alleviates any pressure that might be building up in their stomach. And we can siphon off any fluids or feed materials and any additional gases in there. And we use an ultrasound to take a look and see. Horses are very, very big animals. You're not able to appreciate everything that's going on with the GI tract, but you can get a quick peek and see if you can appreciate any abnormalities. We may or may not do an abdominocentesis. This is where we insert a teat cannula into the ventral abdomen and collect some free fluid from the abdomen and see what we can appreciate there. And then, of course, if they need fluids or additional treatments, we are going to place an IV catheter and give them such treatments. Colic workup can be done anywhere. If you're out in a field, in a barn, you can do it there. If the person doesn't have a barn and you're just out in a field, you can do it there. We choose to do it either in a set of stocks, kind of keep the horse contained, or if the horse is very agitated and that's not going to be safe, we would do it in one of our recovery boxes, which is a padded room, so it's a little safer in case the horse were to go down. So, causes of colic. This is additional information that you may or may not need, but knowing why the horse is colicking helps you prepare for what comes next. What kinds of treatments are you going to be doing with this animal? What do you need to get out? Do you need a lot of fluids? Is the horse going to be on fluids all night? Or are you going straight to surgery to fix this? So I will briefly talk about the types of colic that we most commonly see. And the first one is called a large colon volvulus. This is when the colic twists around itself, around its own axis. Horses are designed very poorly, you might say. Their GI tract is only attached to their abdominal wall in a couple of places. We as humans, all of our organs are just firmly attached to our body wall so that they can't go anywhere. Unfortunately for our horse friends, that's not the case for them. Their whole GI system pretty much is kind of a free-floating fluid can be mess. So what can happen is the large colon can twist around itself. Causes a lot of pain, as you can imagine, and it compromises blood supply to a portion of the colon. It can happen at any point along the large intestine, but it usually happens where the large intestine meets the cecum. And unfortunately, brood mares in their last trimester to 120 days postpartum tend to be predisposed to this type of colic. This is a type of colic that is only corrected with surgery. So if you are not going to take this animal to surgery, it should be humanely euthanized to prevent it from suffering. They do not fix themselves. Excuse me. Left dorsal displacement. So with this, the left colon moves up and over the rhinosplenic ligament. And what they think happens here is that the colon fills with gas and the spleen contracts in response to the pain from the gas distension. And so the colon just lifts itself up and over the pelvic flexure. Excuse me, I'm losing my voice a little bit. And the colon displaces dorsally. At that point, the spleen will refill with blood and trap the colon in that dorsal position, cause some pain, but But there are options here. We don't have to go straight to surgery. You can try administering phenylephrine and jogging the horse to see if the spleen will shrink back down, and then the horse can jostle. Jostle seems like such a silly word, but jostle its intestines back into place. Right dorsal displacement, the colon becomes trapped between the cecum and the right body wall. And again, this is not an immediate surgery. You can wait it out. It does cause some pain, so you can give them fluids and mild analgesics and see if they can correct themselves before jumping straight to surgery. Impactions. An impaction is a clog in the pipe. That's all it is. Excuse me. A blockage of the gastrointestinal tract. So for this, you can try giving fluids and electrolyte water and seeing if that blockage can hydrate and pass, or sometimes we do end up going to surgery. This is a picture from one of our cases. So heavy parasite burdens lead to a worm blockage. Usually it's roundworms in horses, and it usually happens in a younger animal. So animal that's being dewormed for the first time, if they have a heavy parasite burden, those worms will die off and then block the intestinal tract. And yes, we do have to take these horses to surgery in order to clear the blockage and take out all the worms and then wake them back up. Strangulating lipoma. This is a fatty tumor that hangs on a stalk, which is called pedunculated. And what happens is sometimes the wind blows from the west and that little pedunculated tumor will swing up and around and start strangulating the intestine. Can cause mild pain, can cause severe pain in our more dramatic friends, and surgery is the only way to correct this. Small intestinal intussusceptions. This is one of my favorite types of colic to go to surgery on. It's very interesting to me what the body will do. But basically, the intestine is hypermodal, and so it kind of eats a less modal section of intestine, and the hypomodal intestine gets sucked into the hypermodal intestine. It does cut off blood supply. It does require a surgical resection and anastomosis, and it usually involves the ileum, so the small intestinal thing. So that's it for the quick and dirty on colics. It can be all or nothing. You never know what you're going to get. Sometimes we hear, oh, there's a terrible thrashing colic coming, and the horse walks off the trailer, it passed its gas, and it feels much better. And sometimes we get a thrashing colic that truly needs surgery right away. So the next emergency that we see quite a bit of is a fracture. There are different types of fractures. An incomplete fracture is when the bone splits or cracks, but it doesn't break into two complete separate pieces. This is a stress fracture usually, and it just repeated. And a complete fracture is when the bone does separate into two separate pieces. And if it's in more than two pieces, it's a comminuted fracture. So all terms you may hear in your practice or hear talked about, but a complete or comminuted fracture is going to occur during intense exercise. This is when the racehorse breaks down on the track and you hear later that it had fractured something. Also, we see them after a horse gets kicked or has some other sort of severe accident or car accident. So fractures are terrible and they're stressful, and you would think that because something that's this big of a deal is coming, that we would get out everything but the kitchen sink. But really, a fracture is the easiest thing to set up for and be prepared for. Again, you always want your stethoscope and thermometer. Just a good thing to always have on your person. But really, all we need is radiograph equipment, because you're going to want to know exactly what that bone looks like, or the veterinarian will anyway. And if you're me, you want to know as well. Maybe you're running blood work. Maybe this happened a while back and you want to see what their status is. And you always want to have some splint and cast materials at the ready. I have seen horses with terrible fractures arrive with their leg bare and completely unsupported on a trailer. So I like to have my splint and cast materials right by your front door. If you're going out to see them in the field, maybe you have it in the truck with you and bring them along. If you're in the field seeing these and they're fractured and the owner wants to pursue treatment, you stabilize them for transport. If we at the referral hospital are receiving them, we need to make the decision, is this something that we want to pursue or the owner wants to pursue? And if so, do we need to cast it or do we need to go to surgery and stabilize it with screws in place? Sedation is pretty much always necessary. They don't like to be manipulated and poked at when they are fractured. It hurts. Having fractured something myself, I can confirm it hurts. So we do the exam wherever the horse is comfortable and able to get to. If that's right inside the door or front hallway, that's where we take the radiographs. If they make it to a stall, fine. If they are not fractured like we thought they were and they want to walk all the way to radiology, that's okay sometimes. This is a fracture that we received a while back now. It's a P1 fracture, and it is complete comminuted P1 fracture. There were multiple pieces in there. This is I think when she arrived, she was like 2 months old, filly, that mom stepped on her. It was a complete accident. She ended up with us. She went to surgery, ended up with us for about a year. We weaned her. We trained her on how to pick up her feet and how to lead like a ladylike little filly. And she did end up going home. She is not able to be ridden, but she was pasture fed. Lacerations are common. Anyone that knows horses knows that they're kind of flighty beasts sometimes, and they like to run away from things, and sometimes they run right into trouble rather than running away from trouble. So a laceration is a slice or a tear through the skin or a membrane on or in the horse's body. This creates a wound. So when you have a laceration that you're going to work with, it's kind of dependent on where the laceration is located. If the laceration is on a distal limb, you want tourniquets to slow bleeding. You want sterile lube to put in the wound and clippers to clip around the wound. The sterile lube is so that the hair that you're clipping doesn't stick in the wound itself. Gauze and lap sponges are always a good idea. And then maybe you want probes so that you can stick a probe, a sterile probe in the wound and radiograph to see just where that wound goes. Maybe you want some saline and Travenol or something to flush with. And sometimes, if the wound has happened recently enough, we can suture it closed, depending on what's going on. If it's not on a distal limb, maybe it's on the head. Obviously, you're not going to use a tourniquet if you put a tourniquet around their neck. So you're going to be doing other things. You can forget the tourniquet, but maybe you still want the rest of the stuff. Suture, instrument packs, maybe if it's on a limb and you want to start regional limb perfusions, which is where you're infusing antibiotics directly to the area of that wound rather than doing just systemic antibiotics. That might be a good idea too. And then of course bandage material, because no matter where the wound is, I guarantee you that horse is going to scratch at it and open it back up if you give them the chance. So I did put in some pictures just for funsies of different lacerations that we've treated over the years, and some that were not ours that I got permission to use. So this little friend did not want to get in the trailer. And what do we do if we don't want to go in our trailer? We throw our head up and we throw a little hissy fit, and we bang our head because we're tall, and we crack it open. This was a pretty easy one. It was a late night, and of course yours truly was on call, so I got the joy of going in and having fun helping to repair this one. Pretty easy, a little bit of sedation, a little bit of lidocaine, some cleaning, and a lot of suturing, and the horse went home. I eyelid lacerations. I don't know why, but we seem to get a lot of horses that like to catch their eyelids on trees. All of you have seen that as well. But it's something that we see a lot of. Again, usually pretty easy to repair when it's just a little flap like this. A little bit of sedation, a little bit of lidocaine, and some suturing, and they come back together just fine. This is one of my all-time favorite lacerations that we got to help with. This horse ran through a gate opening at the same time as one or two other horses. He was on the side with the gate latch, and he lost the gate latch. The gate latch caught him, and it must have been pretty sharp. He was a very lucky horse in that there was no opening into his abdominal cavity. All of that muscle and tissue was completely intact. So although we could see his intestinal peristalsis through that muscle layer, there was no breach into that cavity. So Dr. Koppelman, who you see in the bottom right there, she is no longer with us. She finished her residency and moved on. But she and I and a couple other people spent a night cleaning and putting this horse back together. He did end up doing fine. And as far as I know, he's still fine. But he required many Penrose drains and things like that to put him back together. Puncture wounds, along the same line as a laceration. This friend, I think it was a tractor accident. I think maybe a baling fork, I'm not sure anymore. But created a puncture wound into the thoracic into the thoracic cavity. So there was nothing for us to close. What we used then is a stent bandage, which you can see in the right picture there, that green towel that's rolled up. And then we use umbilical tape to basically make shoelaces to hold it in place over the opening. And then we keep that wound clean and dry as possible and let it granulate in so it heals through second intention. Of course, the horse is also on antibiotics to ensure that we don't get an infection. That's another fun injury that we see quite a bit. Distal limb injuries, horses love to get them. They love to fight with the fence. They love to fight with everything that they can find. So this is one that we got in. It was pretty superficial, just a little slice through the skin, so we were able to clean it up, suture it closed. This horse did get a regional limb perfusion or two, and then some additional antibiotics. When it was time to go home, oral antibiotics and bute, and the horse healed up fabulously. This is a case where you can use a tourniquet, obviously, because it's a distal limb, and you would be able to put a tourniquet on above it if the horse was bleeding profusely. Dean, this guy. So this guy had a fight with a piece of old farm equipment that lived in the pasture with him, and it had always lived in the pasture with him. And then one day, for some reason, he got his foot caught in it. And as we all know, horses aren't always the calmest creatures when they feel trapped. So he started twisting his leg. And as a result, he sheared off part of his foot there. And he came to us in pretty poor shape. Infection was setting in. They had tried to treat it a little bit at home. Infection was setting in, and he had bled a lot. He ended up with all sorts of treatments, antibiotics, a blood transfusion, or two, I can't remember, maybe two blood transfusions, wound management. And he lived with us for quite a while. And then he was able to go home and be managed at home. The picture on the right is 6 months post-injury. He came back for a recheck, and he was looking pretty good. He did eventually, he was a draft horse, if you can't tell by the foot and the leg. He did eventually end up with some pretty severe arthritis due to his injury. But we gave him an additional, I think, 2 years post-injury before he died. This is not one of our cases, although the emergency nerd in me would have loved to have seen it in person. This is a case that Iowa took in. One of our former residents now works as a clinical instructor at Iowa State, and they took this horse in, and he right away started shooting pictures and said, oh, you would have loved this and things like that to me because I am an emergency geek. This horse, I don't know the whole backstory. I don't know how the pole ended up where it was. I do know that they were able to CT this horse's head and that the pole missed all critically vital structures. So they were able to remove the pole. And you can see throughout this series of pictures how the horse looked as they managed that wound. Eventually it did all granulate in. I have no idea where that horse is today, but I had to include it because it's one of my favorite, I guess you'd call it a puncture wound, one of my favorite puncture wounds that I've seen yet. So the next thing I'm going to talk about is choke. Choke is not the same in horses as it is in people. In people, it is where our airway is blocked, so we can't breathe. Choke in horses is a condition where their esophagus is blocked, so they can no longer eat because their esophagus is blocked by something. So the horse can breathe just fine, but they can't swallow any water, and they very quickly become dehydrated. So these horses are going to be coughing, they're going to be drooling or salivating, and they may have material coming out of their nostrils, so coming back up as opposed to going down. Pictures of horses coughing, drooling, or salivating, and with feed coming from their nostrils, in case you had a question about what that might look like. This bottom left one, that is not our hospital. That is somebody's house. I would like everyone to know that the University of Minnesota does not have open wood stalls and dirty floors. So a choke workup, what are you going to do? Well, if you're out in the field, you're going to grab your handy dandy thermometer and stethoscope. You're going to assess your patient. You're also probably going to try and pass a nasogastric tube. And that is because you want to know how far down the blockage is. And then if you can get to the blockage, you want to try and flush it through. So you're going to use a nasogastric tube and some fluids, a fluid bolus, to try and push that blockage down. In which case, the horse will probably be fine, and there's no need to take the horse for further treatment. If in the field they cannot clear the blockage, the horse ends up coming somewhere like our hospital. And at that point, we also would try and pass a nasogastric tube, but we would also use an endoscope and we would visualize the blockage. And we may use some esophageal forceps and try and grab the blockage back out if we can reach it. If the horse is dehydrated, as most are, we would place an IV catheter and give it fluids to support it, and put whatever electrolytes are indicated by the horse's blood work into those fluids. Usually the horse does need to be sedated. They don't like this. Passing an endoscope and putting a long pair of grabbers down through their nose and down their throat isn't something that they love. So, passing a nasogastric tube on a horse, you can see that our friend on the right there has a twitch that she's holding on to. That helps to kind of keep the horse's mind off of the nasogastric tube and on the twitch. The twitch helps to release endorphins and help the horse be calm. Then as you can see, that nasogastric tube is in the horse's nose, and what you can't see down below is that they are pumping fluids through that nasogastric tube, trying to get that blockage to to flow on down to the horse's stomach. So on endoscope, what does it look like? The picture on the left is not one of my patients. The picture on the right is from our endoscope. Unfortunately, the picture on the right, it shows that the horse ate some sort of wood chip material. Not the best life choice on that horse's part, but it is something that happens now and then. So as you can see, we have an esophageal forceps in that image, and we are trying to grab pieces back out. The picture on the left is a feed bolus, it appears to be. That's blocking. Okay, so I had to include a couple of weird cases because it's just kind of fun. And this one came to us as it came to us as a choke case, and then we figured out there were additional things going on. So this horse presented during daytime hours. It was not actually presented to us as an emergency, although it ended up being an emergency. So the horse presented with a swollen neck. In addition, we found that the horse had an elevated temperature, was pyrexic, elevated heart rate, and was not hungry at all. The neck was so swollen that I don't think we could have tried to feed very much anyway. On blood work that we ran, we found an elevated white count, indicating infection, and an elevated PCV. The horse was dehydrated. So we decided to go further and do some diagnostics. Physical exam indicated all the things that we've already talked about. We did perform an ultrasound of the neck, and our veterinarians found big pockets of what looked like fluid in the neck. On endoscopy, we didn't really see much. Nothing that would explain what was going on anyway. And then we had run the blood work that I told you about. So we decided eventually that this horse needed to go to surgery, and we needed to evaluate why there were these pockets of fluid in his neck. So we scheduled surgery under general anesthesia. We have an anesthesia team that services our hospital, so they did come up, get set up, and we were able to put him under general anesthesia pretty much right away. So upper left, I know that's not the picture you guys are looking at now, but I'm going to talk about it anyway. Because his neck was so swollen, we had to place a lateral thoracic catheter on this horse. We could not access either jugular vein because the swelling was so diffuse across his neck. Now, when we got into surgery, again, my emergency nerd inside of me was excited. I didn't quite know what we were going to find. But what ended up being found was, you can see in this middle picture here, that's one of our surgeons, and in his hand is a pile of bloody feed material. What we determined had happened is this horse had choked. And what we found out later is that they cleared the choke on the farm with a nasodiasis tube, just like most would. Unfortunately, what no one knew is at some point his esophagus ruptured, and you can see very clearly the holes here, the tears in his esophagus. So as he kept eating, feed material was going out into his neck, into a space that was not prepared to receive that material. And he had pus and infection just kind of raging in there. So unfortunately, we did euthanize him on the table, but it was a very interesting choke-related case, and not something that you ever expect to find. So, neurologic horses, we see them. They can be emergent. They can come in as just a normal day appointment for us. But the reason that they're neurologic, kind of like with colic, can be wide and varied. The nervous system is made of the brain and the spinal cord and peripheral nerves. So depending on what part of the nervous system is affected will determine how the horse moves, how the horse looks, and what the horse is doing. Clinical signs of neurologic disease. These are the most common that we see: ataxia, hind end weakness, head pressing, muscle fasciculations, seizing, limb paralysis, and of course, impaired vision. They can go blind due to neurologic disease. Horses that are a bit ataxic, they don't quite know where their feet are going. The one on the right here, this is our radiology room. And this porty thought everything was right with the world, but when we stopped moving, the hind feet went one way and the front feet went the other way. Head pressing, we will talk about putting helmets on both people and horses, and this is why, for the horses anyway, you want to have a helmet on them so that they protect their head. And in weakness, we do something called a tail pull to test how strong their hind end is while they're walking. You should not be able to pull a horse over, but with some neurologic disease, you can come pretty close to just giving a little tug on their tail and pulling them right over. And then, of course, limb paralysis, they end up dog sitting or completely recumbent. I do have a couple pictures of seizures. There are different seizure activity. They don't all look the same, just like all seizures in people aren't the same. All seizures in horses aren't the same. So I will try and play these videos for you. Very simple paddling. And in addition, as soon as she would stop paddling, she would, gosh, I'm sorry, I'm getting button crazy on you. When she stopped paddling, she would do this with her mouth. So it's paddle, 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 lick, lick, lick for her. This one was a little bit different. Just a little focal seizure. And when that was done, it would progress to something like this. Apologize for the video. And still we have this one, and this is out on a farm. So again, the video quality isn't the best, but you can kind of see what this horse's seizure activity looks like. Very different. Please don't ever hug a seizing horse. If I'm there, I will grab you by your collar and drag you away. My coworkers who are listening know this of me. But yes, very dangerous to be around a seizing animal. You can't stop them. They're going to go through their seizure activity, and they're big enough to really injure you if you're in the way. The causes of neurologic disease, EPM, West Nile, wobblers. Wobblers is common in Doberman pinschers. It also happens in horses. And then equine herpesvirus 1 can morph into EHM, and rabies and tetanus, and then of course trauma. All common causes of neurologic disease here. So what do you need for neural workup? You're probably going to run blood work of some sort if you're capable of doing that. You're going to do a physical exam and or neuro exam with things like a tail pull and doing things to assess if the horse knows where their feet are and how stable they are. If you're going to see a horse that is recumbent, you might need a skid and some some hands and some muscles to get that horse moved. In the hospital, if we hear that we have a recumbent horse coming, I have the skid ready by the front door, and some big like fireman straps so that we can get the horse off their trailer onto our skid and into the hospital as soon as possible. And then in the hospital, we use things like the slings to lift the horse if need be. A horse can't be down on the ground for too long without damaging nerves and muscle. So we use slings to stand them up and or flip them over. Helmets, I mentioned this for people and horses. We had one neurologic case that damaged and injured 4 people. So helmets are a big safety thing when you're working around a down animal, whether it's a horse or a cow. Safety should always be top of mind for you. And then in the hospital, they're probably going to need a catheter, some IV fluids, because they're not necessarily eating properly. And if we think that it's trauma related or that they might be a wobbler, we're going to take radiographs of their neck. So the slings that I mentioned, we have 2. We'll be brief because I know I'm going long here. I have a few more slides yet. The large animal lift, this is a really lightweight sling. It's easily mobile, and it will fit anything. You can use it on a power lead and it'll fit. This is what they use in rescue situations for the vertical lift or the forward or rear assist, if you ever watch any of those shows where they drag horses out of ravines and so on. But it can't support a horse long term. It can get them up off the ground, as I used it for with this horse. But they can't live in it for a long time. Like if they have EPM and they need assistance standing, this is not the sling that they will live in. The hand sling is more supportive. They can sleep upright in it. This is the sling that they use to airlift horses, if you've seen that on TV or anywhere. And this is the one you want to use for long-term management. The downside to this one is it's really hard to put on a recumbent horse. So often we use the large animal lift to get them up off the ground and then switch them into this one for long-term management, as I did with this horse. And then the skid I mentioned, it's made of recycled plastic, made for us, and it has lots of handholds and tie-down areas so that you can safely move down an animal. You do usually have to heavily sedate a horse, safely move them, and usually one person is dedicated to monitoring that horse. That person usually rides with the horse on the sling to make sure that they are staying down and out and that no body parts would be escaping the sling and things like that. This is not one of ours. This is a practice. Gosh, I can't talk. This is a training thing that they did for rescuing horses. And what they did is they put this horse on a skid, sedated, hobbles, tying its legs up off so that they don't drag on the ground, and they got it from where it was. Dystocia, I will go through very briefly because we all know dystocias happen in all species. It is an abnormal birth or a difficult birth. Usually in horses, it's the full head or forelimbs that are causing the problem. Foals are very gangly and their bits tend to get crossed. This is the dystocia that we did. You can see we have no shortage of staff at our hospital. So in the picture on the left, you can see some of our anesthesia team, a surgeon, and at this point, we weren't even going to surgery. We were just going to try and manually get this foal out, but at the same time, prep for a C-section in case we couldn't get the foal out. So you can see on the right, Dr. Medill, our Thurio doctor, was trying to get the baby out. He was successful. Baby came out. This baby did live, but needed a lot of support to begin with because there was some airway compromise when he was stuck. I have one last case study that I will go through. It's just kind of an interesting one, and then I'm happy to stay on and answer any questions that you guys have. This horse came to us after hours, and this is several years ago now. He had been out in his pasture during the day, and owners were at work. This normal day, he's out mowing down the lawn, and for some reason, at some point, his tail got caught on the fence. And then for some reason after that, he pulled hard enough to deglove his tail. So they managed him for 2 weeks on the farm at home with the ambulatory veterinarian, and were doing pretty well. They had him on antibiotics, they were cleaning the wound and doing bandage changes, and then suddenly they just started to lose ground, and they decided to bring him in for further treatment. And when we got to him, this is what we found. The tip of the tail head was necrotic, was very cold to the touch, and this is how he looked when he first walked in through our doors. He's actually standing in our exam room there. Just for funsies, I got the radiology equipment, brought it to the room. Now, this is not our highest powered radiology equipment. This is our ambulatory equipment. So it didn't quite penetrate him perfectly, but you can see in this radiograph that I took that he had subluxated his spine when he pulled so hard. So he pulled with a lot of force. It was determined that we needed to clean up the edges a little bit and amputate the dead part of his tail head. So that is what we proceeded to do. We went to standing surgery. He got an epidural block so that he would not feel anything, and a little bit of light sedation as well. And we proceeded to amputate the dead part of that tail. You can see that is a piece of vertebrae sticking out there. We did have to remove that one last piece so that we could close up the tail. That's what it looked like left there when we were done with surgery. We proceeded to close it, suture it shut, and then the picture on the right is a little while later. I can't remember the exact timeline, if it was a couple, maybe almost 2 weeks later. That's what it looked like. He is, just FYI, alive and well and tail free. He can no longer jump high fences like he was born to do because of that subluxated spine. He's not completely stable, but he's stable enough to walk around and be a very, very happy horse. So that is all I have to say about that. One last plug I have, if anyone is interested in working with cases like this, we do have a position open right now at our hospital. And if you are interested in investigating more about what it would be like to work there, you can ask me any questions you'd like to, or you can go to this website with the job number and you can investigate it there as well. So thank you. Thank you for having me tonight, and I am happy to answer any questions that you guys might have.
Thanks so much, Shana. A reminder that if you do have any questions, so please type them in the Q&A area. I'll give you a minute or so now. We did have one question that popped up. Have you ever been in on a esophagotomy surgery for a choke where the incision is in the lateral aspect of the neck?
I have not. I have watched many, well, I can't say many, a few videos, and I have heard of others that have done it, but I have not been a part of that at the university.
Great, thank you. And I don't see any other questions right now. But please definitely, if you do think of a question or have a question, feel free to, I will give you my email here in a second. Feel free to email me and let me know, and I can forward it on to Shana for you. So I'd like to thank, take this opportunity to thank Shana for her time and informative presentation. The MVMA will be emailing you a link to the evaluation within the next few days, and would greatly appreciate if you could take a few minutes to fill it out. We do analyze the evaluations to help improve future CE offerings. Also, you will receive your CE certificate at that time as well. And then there was a question as far as providing your PowerPoint presentation, Shayna, we would be able to provide a link as well if Shayna is allowing us to show that as well. So we can include that in the email to you guys as well. Yeah, but otherwise, yeah, if, again, my email address, you can email me any questions, is Maria, M-A-R-I-A-N as in Nancy, so Maria N at mvma.org. So again, thank you again, Shayna. It was a great presentation, and I hope you guys all have a great evening and a great National Veterinary Technician Week.
Thank you. Happy Tech Week, everybody.
Thank you, everybody.